Hi, welcome to the ITSAN video podcast. Today, we are so excited to welcome Dr. Julie Greenberg. She's a licensed naturopathic doctor. She's a registered herbalist. She specializes in integrative dermatology, and she's really passionate about natural skincare. She believes that many of today's chronic skin diseases can be healed by using evidence-based natural alternative treatments. She takes a holistic approach to healthcare and treating the whole person holistically and looking for root causes. So this is a reminder that Dr. Greenberg and ITSAN, we're not giving medical advice. We always recommend that you find a licensed practitioner. We have a list of recommended practitioners, TSW supportive practitioners on our website and also our support group. So welcome, Dr. Greenberg. Thank you so much. I'm so excited to talk to you today.
Thanks so much for having me. It's a pleasure to be here.
Thanks. So let's get started. I know you specialize in eczema. Can you tell us a little bit about the differences between eczema and TSW and kind of how to spot the warning signs of maybe TSW developing while you're, thinking it might be worsening eczema?
Yeah, so let's, I'm going to pull up some slides so that you guys can see instead of just hearing my jaw flap. Let's kind of set the stage for eczema, because even though it's possible to get TSW as a result from using, topical steroids and other medications from other diseases, I would say the vast majority of patients kind of get to TSW via an eczema route. So what is eczema or atopic dermatitis? And these terms are used interchangeably. Atopic means allergic and dermatitis just means a skin inflammation. So that tells us something in the name about what's driving it. But I take patients through this through a very long presentation. I'm just going to take your listeners through a little bit of it to set the stage so we can understand what's going on. So fundamentally, what is eczema? It's a disease of skin barrier dysfunction. I think anyone who's had eczema or anyone who's had a child who's had eczema is well aware of this. The skin is not functioning as it's meant to. But it's also a disease of inflammation. And the inflammation is not just happening on top of the skin, it's happening systemically. And to understand the immune response that's happening within eczema, we have to take a little tiny sidestep to immunology. And most of my patients are not medical professionals, but I take them through this because I think it's important for us to understand what's happening in our body, in our children's bodies. We don't get user manuals, and we kind of hear these things thrown around, but we don't really understand it. So I'm just going to take a few minutes to explain what is actually happening in eczema. So we have to go to the immune system, and we have certain cells in the immune system called T helper cells. So we see the TH. And probably a lot of people listening to this have heard the term Th2 cells when it comes to eczema. And that is because this is the main pathway that's driving eczema within the system. So if you or your child has eczema, you guys are building a huge army of Th2 cells to go fight what the body is viewing as invaders. And let's see what would drive this process. So it starts with our organ systems that interface with the outside world. And I think the most obvious organ system is our skin, right? It's built to interface with the outside world from the minute you're born until the minute you die. That's its job. Work with the outside world and keep you safe. Other organ systems that interface with the outside world is our respiratory tract. Right now, I just took a breath in. That air came from the outside. It can be full of pollens, COVID, all sorts of things. And I'm bringing the outside world into my body. And then our digestive tract is certainly an organ that interfaces with the outside world. Every time you take a bite of food, a drink of a beverage, even swallowing saliva, you're bringing outside world and putting it right in the center of your body. So this is all dangerous, right? This all is possible for pathogens and bad guys to get into our system and hurt us or possibly kill us. So the immune system is constantly sending signals from these organ systems to the immune system, like, hey, did something bad just get through? Did COVID just get through? Do we need to worry about this and build an immune response? And the cells that dictate that, they're called dendritic cells. And these are like the passers of information. So they're going to take, if you breathe something in like COVID, the dendritic cell is going to pass this information to your immune system, to your T cells, and say, okay, I just saw this new thing. It's COVID. I don't think it's good. We better build an immune response and fight this right now. And so when we first build a T cell in our body, they're called naive T cells because they're waiting for instruction from our body. Okay, what should I be when I grow up? Where do you need me? Where's the threat? And it's the same as our US Armed Forces. If we see a threat coming by sea, we send the Navy. We see a threat coming by air, airplanes in the air, the Air Force is on it. And if somebody is attacking our land borders, we get the Army with the tanks on board. Body does the same thing. And so that's this process of the dendritic cell activating the naive T cell and saying, this is what I want you to be when you grow up. Here's where I see the problem. So in people with eczema, this process is happening. It's activating T cells and sending them along this Th2 pathway. So once we create a Th2 cell, it's going to create these things called cytokines. These are inflammatory chemicals that the body uses to fight the invaders. Now, sometimes the invaders are real, and sometimes they're kind of imagined by the system. So when we look at, well, what's going to drive an army of Th2 cells in somebody, we can see that worms or helminths, fungi, and allergens. So again, we get back to this atopic dermatitis, allergic dermatitis. The body is thinking and seeing all of these allergens, all of these things that shouldn't be there, and it's building this whole Th2 army. And as long as somebody is having a flare with eczema, they're building a huge Th2 army, and this army is releasing IL-4, IL-5, and IL-13. These are the inflammatory chemicals that drive and kind of perpetuate the process. Now, eczema is more complicated than just this, and there's very interesting research showing that in different people, there's a multitude of armies being built. So there's a lot of Th1 response, and in some individuals, another response called Th17. And Th22 is involved in tissue inflammation. So I know this was pretty sciencey, but we have to understand that eczema is not just a skin problem. This is a systemic response that's happening. And I get into it more with patients, but it's being driven via the gut, via a leaky gut, via leaky skin. These are driving this allergic response. And so this is the stage for eczema. This is what we know is happening in eczema. TSW, we don't know even a fraction about TSW and what's happening in the body as we do with eczema. TSW is this kind of secondary response, and you need to have a condition like eczema where you're using a lot of things like topical steroids to then get TSW. And TSW, we've talked about it before, topical steroid withdrawal, I don't think is a great name because it makes it sound like the only thing that causes it is putting topical steroids on. Well, most of my patients that I see, the kickoff point, the thing that puts them over the edge, a lot of them have had to take oral prednisone to control really severe eczema. And for a lot of them, that was really the tipping point where the TSW hit them. Maybe they've used topical steroids for years, but we'd get a round of oral prednisone because the eczema is so atrocious, and now they're in TSW. The TSW can also happen from the calcineurin inhibitors, so things like tacrolimus, pimecrolimus. It can also happen from like Elidel or Eucrisa, the PDE4 inhibitors. So it's not like the best name, but TSW is a secondary disease that we get. It's called an iatrogenic disease, which means that it's induced by medicine, and it's caused by the overuse of these products, oral or topical, that try to inhibit the immune response. So basically, we're not going back to this level and saying, okay, why is the body causing this building of armies? No, those things and Dupixent is a Th2 inhibitor. All of the things that we're using pretty much for eczema, they're out here and they're trying to push that inflammation down and say, no, body, don't respond. You see an invader, you're trying to mount an immune response. No, we're going to push it down and we're not going to let you respond. But it doesn't address the problem down here, which is that an organ system saw a problem and it's triggering the immune system to go fight it. We're not conventionally dealing with it down here. And it's this pushing down of inflammation, year after year with topical steroids that causes the TSW. So TSW is built on top of eczema.
Wow, that is really informative. And I love being able to see it right there, just all mapped out like that. So my big question when I see this, so I think of that game like whack-a-mole where, it's almost like inflammation is the mole and you keep trying to pound it and it comes out someplace else.
Yep.
So if we don't know specifically, I don't think many people are testing, if you're Th1 dominant or Th2, or I don't think many people are testing to find out, what exactly your body response is doing, number one. So you're kind of like going in blind and shooting at the dark. And then also, again, like you said, we're not really looking at why the inflammation is happening in the first place.
Yeah, I'm going to show you a picture of what happens when we play immune whack-a-mole. So Dupilumab or Dupixent, it's the same medication. Dupilumab is the generic name and Dupixent is the brand. But if your listeners aren't familiar, it is an injectable biologic that's used in eczema. And as I said a minute ago, it suppresses that Th2 cell response. So when we inject with Dupilumab or Dupixent, we're pushing down the Th2 response. Well, we've seen a whack-a-mole effect where when we push down Th2, Th17 pops up, and it's called a Dupilumab dermatitis. So there's lots of cases now where folks who are taking the injections of Dupixent are getting these crazy rashes on their face and neck that look kind of like this.
Yeah.
We've called it Dupilumab dermatitis. And in this case study, but there's many more now that have come out, they took like these 5 adolescents who developed this type of response. And they hypothesized that maybe this was a fungal response. So we have a yeast living on our skin called Malassezia. It's totally normal. Malassezia is on every person, every warm-blooded animal. There's like 18 different species. Normally the immune system sees the Malassezia and is like, it's Malassezia, walk on by. It doesn't do anything. But this is kind of an area where it's called seborrheic dermatitis is kind of the rash that can be caused by Malassezia. We can also get dandruff from Malassezia. And these researchers said, okay, this looks a little like a Malassezia response. Let's give these folks who are on Dupixent and having this rash oral antifungal drugs called fluconazole for 5 days and see what happens. And after 5 days, all of them basically cleared. And basically, the researchers hypothesized that it was immune whack-a-mole, that Dupilumab was this Th2 blocker, that we're pushing down the Th2 response. Well, when we have an immune response to Malassezia, it's a Th17 response. And we don't know why, but Dupilumab crushed the Th2 response, and the Th17 response was like, okay, if you won't let this way, we're gonna have this immune response, and it causes the immune response and rash to Malassezia. So immune system whack-a-mole.
Right. So what is the answer to that? So obviously,
well, I think the answer to it is that, right, we're going about it all wrong. And so psoriasis, for example, a lot of times people come to me and they're like, oh, psoriasis and eczema, the same thing. No, they're very different things. So psoriasis does not involve a Th2 response. Psoriasis is a Th17 response. Now, psoriasis has a lot of drugs and injectables that come in and suppress that Th17 response. And we can get a good clinical result, again, in that people's psoriasis will kind of start disappearing, but there are side effects, to suppressing the immune system. I think we have to go back and relook at, like, where are we trying to hit the problem? And so if we go back to the chart, which I'm going to get us back to, we should stop trying to suppress the immune system. And what we really need to do is go back to what's causing the problem and let's fix it. So instead of working out here to crush the immune response all the way at the end, let's come back here and say, what's driving this? What is the body irritated by? Let's stop this process so that we're not mounting an immune response. And that's more of a naturopathic or functional medicine approach, where we say, treat the root cause. And all of my patients who come to see me and people like me, the words, I want to treat the root cause, it comes out of all of their mouths, because I think people know this isn't sufficient, right? This isn't working. It's not good enough. We need to go back and ask, like, why is this happening, and fix it here? But it's a much more complicated process, and it's not the training that conventional medicine puts doctors through right now, unfortunately.
Yeah. Wow, that's really, really helpful to see. So, so what exactly is happening then? So obviously we've suppressed our immune system in some way, whether it be any, oral or topical drug during using it for eczema or any other kind of skin condition or whatever it else might be. So we've suppressed our immune system. It's angry. And it's showing up in other places. Now we're going through this whole withdrawal process that I understand is connected to nerve endings, and it can affect your HPA axis. Maybe we can talk a little bit about that, and the adrenals. So we have two issues here. We need to figure out how to, stop suppressing our immune system to treat these conditions. And now we have this, something that showed up afterwards that we need to handle as well. So can you talk a little bit about that?
Yeah, so we'll kind of stick to the steroid part of topical steroid withdrawal, and let's talk about steroids, topical steroids, oral steroids.
Yeah.
I'll start off by saying every doctor knows that if you have a patient on oral steroids, so prednisone is an example of an oral steroid. If you have a patient on oral steroids for long enough, you have to do something called tapering, which is, let's say they're at 60 milligrams a day for a long period of time. You can't just one day say, okay, stop taking your prednisone, you're done. No, you have to taper. So now we go down to like 50 milligrams for a while. And then, okay, we're down to 40. And you have to taper it down until you can get someone off of it. And the reason is, every doctor, this is like 100%, you'd be committing malpractice if you didn't do it. We know that when we take oral steroids, or it's like an oral cortisol, basically, we're shutting down the body's production of cortisol. So cortisol is produced like in the adrenal glands, and it gets the signal from the brain. And we need cortisol. Cortisol is our kind of like get up and go hormone. Like we wake up in the morning, cortisol has to shoot up. And then as we go through the day, cortisol comes down. So it's what we call a diurnal hormone. It needs to rise and fall every day. Wake us up, get us going. Okay, it's the afternoon, it's the evening, come down, and then melatonin takes over. And so constantly the body is getting feedback, like what time of day is it? And how much cortisol is in the body, and how much more do we need to make to keep you going? So that's a constant process. Well, when we take oral steroids like prednisone, the body is suddenly like, oh, wait a minute, where did all this cortisol come from? I don't know. I don't actually care, because it means I don't have to make it. And I got like 100,000 other things to take care of. So adrenals, why don't you just shut down that cortisol production, because we're getting it from somewhere and you don't need to function. And that's what happens, is we shut down the body's production of cortisol when people are on oral like prednisone and steroids for long periods of time. It's why we have to taper. You can kill somebody by pulling them off of oral steroids very quickly. So again, no doctor disputes this. This is well known. Well, let's look at topical steroids. The medical community is like, no, that doesn't happen with topical steroids. You don't get enough cortisone. It's not going to affect the body in that same way. You don't have to worry about it. So I think it's true if you use steroids in the way that you're meant to use them, which is, basically, originally steroids were meant to be used for 4 to 7 days. Like there's some sort of inflammation. All right, you use it for 4 to 7 days. It should reduce the inflammation. And cortisol is a powerful anti-inflammatory. That's another one of its functions. It's powerful. I think most people know that if you or your child first had eczema, if you put some topical steroids on it, it probably worked at first. It worked really well.
Yeah.
Right. And
like a miracle.
It is. It's like, oh my God, look, that's amazing. But again, we have to think we're outside pushing down inflammation. I think if someone can use it for 4 to 7 days, whatever was going on, if it never comes back, that's a great use of topical steroids. I'm actually not against all topical steroids. I am for them being used appropriately, 4 to 7 days. Once you go beyond that, once you're in a cycle where it's like, oh no, it's back and I got to use more steroids, you got to say, this is not working, right? There's something truly more long-term going on in the body that we need to address. So then I think it's an inappropriate use of topical steroids. And we look at people, I mean, I have people who come to me, they may have been using this stuff for like 20 years.
Yeah.
And we're putting it on broken skin. Well, broken skin is going to absorb things a lot more than non-broken skin. And then I'm just going to open up another slide for you. Because there's different steroids. And so let's look at them. Okay. So I'm going to share
So
with
informative.
Because what we do is we start going up the chain.
Right.
So, and there's a mnemonic that we use. Cheetahs run faster than humans. Okay, but what does that mean? So we see classes. So there's from class 1 to class 7 of steroids. I think it's a little counterintuitive, but class 1 is actually the strongest and class 7 is the least potent. So most people start with like a hydrocortisone cream. That's a class 7, it's the least potent. Hydrocortisone is about equivalent to like the cortisol that you produce. But what happens? So you get handed a tube of hydrocortisone and you start using it. And at first you're like, miracle. And then you start using it more frequently and then it's not working. So what happens? Your dermatologist or doctor is going to move you up the chain in classes and potency. Well, it makes a big difference which type of steroid you're on. A class 1 is called a super potent. That is something like a clobetasol. That is 600 times the strength of a hydrocortisone cream. So think about that.
Wow.
One application of clobetasol is equivalent to using hydrocortisone every day for almost 2 years. Like, it's a big difference. And so I think what's happening with people with eczema is you start moving up the chain, you're using it more and more frequently, you're using it on broken skin, and there is systemic absorption that's happening. And over long periods of time, I think even if someone is on hydrocortisone, if they're on it for 20 years, we can get the same effect that we get from like an oral prednisone, where the body's production of cortisol can shut down. It just keeps seeing cortisol coming through, especially through broken skin. You're going to absorb a lot more than, putting it on intact skin. But no one's putting steroids on intact skin. The point is that you're trying to heal broken skin. So you're absorbing it systemically. And I think that that's basically what's happening is we're getting a similar effect. And then a lot of times I hear patients say, and then I just had it with the topical steroids, so I just stopped using them, and then boom. So I actually, when my patients come to me and I'm suspicious of TSW or whatever, I don't say, okay, just stop using them like cold turkey. It's not, I want to get them off it. Believe me, I do, but I don't want it's the same effect where suddenly the body freaks out and it's like, oh my God, I have no cortisol. And then we run the other way because now the body's like looking around and all of a sudden it's like, oh my God, there's no cortisol. And it starts screaming at the adrenals, like, do it, get back online, increase it, fire it. And a lot of my patients, when I test their cortisol is through the roof because now the body is bounced back. Again, we've pushed down the suppression of cortisol artificially. And then all of a sudden we pull the topical steroids and it's just like the body goes crazy and it starts cranking out cortisol to try to compensate. And it's kind of this like boing, 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 right? And it takes a while for the body to kind of rectify. Yeah. And a lot of the symptoms that we get with that like red skin and oozing, it's vasodilation. So it's the blood vessels, cortisol constricts it. And so it's kind of artificially narrowing the blood vessels. But again, when we pull it, you've been holding down the blood vessels and constricting them and they go boing and they open up too much and we get all this blood and fluid to the site. It causes the red skin syndrome and it can cause the leaking, oozing skin that a lot of TSW patients suffer from.
So it sounds like there's a lot going on when your body decides that it's addicted and going through this withdrawal process because your number one, the vasodilation. So you get that whole redness aspect. Then your adrenals are having an issue with cortisol production. So I think the biggest thing is, people obviously know they're going through this. They have thermoregulation, they have insomnia, the list goes on of all these different symptoms. From what I understand, people have tried to taper on topical steroid or their topicals, but they just wind up giving up and just going cold turkey. And also a lot of times they feel like the steroids just stopped working. Like it's not like they wanted to stop using them. They just stopped working, obviously, because maybe their body needed a stronger steroid. So one of the biggest questions I always hear from, people is just like, what are the stages of TSW? And how long is this going to last? So how can you tell are there certain things to test for or kind of figure out while someone is going through TSW, how they're going through the process, or if they're going to be stuck in a certain situation or it's stuck in a certain phase or a flare for a certain amount of time?
Yeah. So, unfortunately, I think TSW is different for everyone, and the stages they go through are different. Some people get the red sleeves. Some people get the elephant skin. Some people get that just like they're like, it looks like they're leaking. Some people, there's so much skin sloughing off, they have to sweep and vacuum every day. It really varies by person. But I think that the problem is that we just can never forget that TSW is built on the eczema. So you have to go back and treat the eczema. And by treat the eczema, I mean, you have to go back and treat, what's driving the immune response, and you have to calm it down. And there's kind of two levels on what's like driving that Th2 response. So for me, I focus a lot on the gut. Leaky gut is going to drive that process. So here we see a healthy gut. This is also a calm immune system. People with a healthy gut, the gut has a pretty interesting job because it has to let nutrients through, right? Life is built on us eating, extracting nutrients. We have to get the nutrients through the intestines. Here's the cells of our intestines into our bloodstream. And then the blood is the superhighway to every cell in the body. We send out those nutrients. Everything from the hair on your head to your pinky toenail is going to get those nutrients. But what we don't want getting through into the bloodstream is bacteria and microbes that live in the gut, and 3 to 5 pounds live in the gut. There's a lot living in the gut, but we want to keep that stuff out of the bloodstream because that's going to activate the immune system. So the body has this mucus. The body produces a thick layer of mucus across the entire GI tract to keep out the unwanted stuff. And that leads to this healthy gut that we're looking at on screen. Well, over here on the right side, this is every eczema patient I've pretty much ever treated. They have a leaky gut. The mucosal barrier has been degraded. And instead of just nutrients getting through, we have bad guys. So LPS stands for lipopolysaccharide or endotoxins. When they come through, your macrophage, an immune cell, is going to grab it, present it to the immune system and say, I don't think this belongs in the bloodstream. The body says, you're right, Mr. Macrophage, it sure don't. What I'm going to do is produce the inflammatory chemicals, IL-6, TNF-alpha, and IL-1 beta. We're going to go kill that guy, and it kicks off inflammation. And this is part of what's driving the army of Th2 cells, is that in a person with eczema, the influx of this stuff from the gut is driving that Th2 response. And until you fix the gut, you're going to have continued inflammation. There's also something that's called leaky skin, and it works a lot like leaky gut. The skin is supposed to be hydrated and provide a barrier to prevent these pathogens and allergens from getting through. So this is that dendritic cell that we talked about initially, that presenting cell. So it's kind of a tattletale, like, ooh, I'm going to show you to the immune system. I don't think you belong here, right? It's like kind of a sleep with healthy skin because nothing's getting through into the deeper layers of the skin. Well, this is more like eczema skin. It's not hydrated. The barrier is broken. Peanut proteins can get through. Allergens, dog dander, environmental pollens. It's getting through the skin. And the dendritic cell is grabbing it and saying, I don't like the looks of you, peanut protein. I'm going to show you to the immune system. And now it shows it to the immune system. And inherently peanuts are not dangerous, right? They're a food source for humans, but some people can develop a deadly allergy to them because the body has been presented improperly and now thinks it's really dangerous and mounts this just crazy immune response to it. So it's a sensitization that happens to an inappropriate presentation to the immune system. It can happen through the skin, it can happen through the gut, and it's firing up all of those T helper cells and creating the army. So I start with healing the gut and healing the eczema. I mean, with the skin, right, we're trying to heal the skin barrier, and there's ways we can go about it, but things don't calm down until you heal the gut. And so my approach is always, whether you just have eczema or whether you have TSW and eczema, I've got to test and treat your gut and calm it down there. And then everything else can calm down, because we're not driving inflammation through the body. Now, I also will do a hormone test for cortisol, because I want to see what's happening with the cortisol. How can I support the adrenal glands? And I support them with like herbs and supplements, just to try to kind of regulate, help the body regulate, so that it kind of can calm down with the cortisol production. But you still have to treat the eczema and what's driving the inflammation. You're never going to get anywhere with TSW as long as the base that it's built on is still driving the truck and the problem.
Right. So back to the root cause again, right?
You have to, yes.
So it sounds like a 3-part approach that you take. So tell me if I'm missing something. So you talked about getting to the root cause, obviously, leaky, looking at leaky gut, doing testing for that, supportive modalities for that, leaky skin, and then supporting the adrenals.
Yeah, it is. So with eczema, it's a 2-pronged approach, right? It's like I need to pay attention to the gut and heal that, and then the skin. But you're right, with TSW, there's kind of a 3rd prong, and it becomes a tripod, and you have to pay attention to the adrenals. And it's difficult because we just don't have the research that we would like. There actually is so much research on eczema when you delve into something like a PubMed, and lots of different researchers have researched lots of different aspects of it, but there's just not much on TSW in the way of research. And so, clinicians like myself who are out there treating patients with TSW, it's more of a clinical approach, which means that it's kind of a trial and error, and we see what's working and what's not. And it varies by person, but I wish the research were there. It's just not right now.
Yeah, I know, me too. So what is a good takeaway from someone watching this? Like, someone going through TSW who's looking for any answers, like what would you suggest they do first?
I think they need to try to get to a healthcare practitioner who believes that TSW is real, because sadly, too many times you hear, well, I went to my dermatologist and they said that it's controversial, it may not be real, and they prescribe me more steroids. That's not going to help. So there are practitioners who understand that TSW is real. And I think you need to go to somebody who's got some experience with it, because otherwise I think you're going to waste a lot of time, with potentially inappropriate treatments. But there are practitioners out there, and I think your website lists a few of them, and it can help make TSW better, get people through it faster. Unfortunately, there can be kind of reoccurrences later on. Even when we've got TSW clear under control, it can kind of come back. It usually doesn't come back nearly as bad as in the beginning. We don't fully understand what kind of triggers that later response. But, I think look for practitioners who have some experience with it. And you can ask the practitioner, like, have you ever seen anybody with TSW? Have you treated it? Because if they haven't, that might not be the best person to work with.
Right. Are there any lifestyle changes they can make on their own, or anything they can do to help themselves?
I mean, for me, like anything that is reducing inflammation and helping the body come into balance. So in naturopathic medicine, we say like there's the fundamentals of health, and that includes things like, what we're eating, getting enough sleep, social and, engagements, like having social support, exercise. Now, the problem is when someone is in severe TSW, you don't really feel like getting together with people because you feel like, oh, I look like a monster. It's hard to exercise and move because your skin is cracked and bleeding and all of that. So I think at that point, trying to focus on food and eating anti-inflammatory foods, which is really going to be plants, making a very heavy plant-based diet, cutting out things like alcohol, sugar, dairy, and wheat, anything that can be potentially, inflammatory or aggravating, and just giving your body lots of nutrients. I mean, the body needs a lot of nutrients when it's losing that much skin and it has to deal with everything. So I think that's the best thing that people can do for themselves at home, is really focus on getting healthy plants and nutrients into their system to support the body and reduce inflammation.
Yeah, that's definitely really helpful. Yeah, it's so true what you said about, not being able to work on those foundational pillars, socially. And there's definitely, it's a topic for a whole other, podcast just about the mental toll that takes place during this. So thank you so much for all of that. I mean, what an amazing amount of helpful information. I know you're going to help a lot of people with that. So tell us how we can find you, if people can work with you or people like you, and where you're located.
Yes, so I am located in California, and I'm licensed in California, Oregon, and Washington. That means I can only see patients who live in one of those 3 states, because even with telemedicine, it depends, the license is tied to where the person is physically located. So if anyone is listening and is in California, Oregon, or Washington, you can go to integrativedermatologycenter.com, and we can see if it makes sense to bring you on as a patient. If people are outside those areas, they can still contact me. I can try to get you to somebody who can work with you in your area. And of course, ITSAN is a great resource, and you guys list providers if they're not in those areas as well.
Yeah, that's true. And you're also on our supportive doctor list, so your information is on there as well. Oh my goodness, thank you so much. I'm so glad we got to talk today. Hopefully we can do it again. There's so much more to discuss, but I really appreciate you taking the time to do this for us today.
You're so welcome, and I hope I've helped at least one person today.
I'm sure you've helped a lot more. All right, thank you. Bye-bye.
Bye.